So today's topic is nerves of the lower limb. So first of all, we will talk about the nerves, and then later on, we will talk about the joints of the lower limb. So regarding the nerves, the first nerve that we have to know about the lower limb is the femoral nerve. It is formed by the branches of the lumbar plexus, and you have to remember this root value, that is L2, L3, and L4. It can be asked in the form of an MCQ. The second point to know is that it is one of the largest branches of the lumbar plexus, and as it supplies a lot of area in terms of sensory as well as motor supply, which we will talk in a while. So femoral nerve is one of the important nerves of the lumbar plexus. So it passes, first of all, we will talk about its root, and then we will talk about what it supplies. So it passes deep to the inguinal ligament and enters the femoral triangle. So as we know that we have the inguinal ligament over here, and then we have the femoral triangle. Now within the femoral triangle, it enters by passing underneath the inguinal ligament, and it lies lateral to the femoral vessels. So vessels will be on the medial side, whereas femoral nerve is going to be on the lateral side. Now, before entering the thigh, the femoral nerve supplies branches to iliacus and pectineus. Now, these are the muscles which are forming the floor of the femoral triangle. So after entering the triangle, the femoral nerve is going to divide into several branches, which are going to supply the anterior aspect of the thigh and its muscles. So immediately after passing under the inguinal ligament, the femoral nerve will be dividing into the anterior as well as the posterior branches. So upon entering the femoral triangle, it is going to divide into anterior and posterior divisions, and they have specific innervations. Now, they are going to supply the muscles of the anterior compartment of the thigh, and this is the motor innervation. So, femoral nerve is a mixed nerve. It has two types of innervation. It has motor as well as sensory. Now, the skin on the anterior and the medial aspect of the thigh and the medial side of the leg is all supplied by the femoral nerve. So up till this area, that is the thigh, it is supplied by the main cutaneous branches from the femoral nerve. Later on, the femoral nerve gives off a specific sensory branch that is known as the saphenous nerve. It is going to further supply the medial aspect of the knee joint and leg and foot. Now, as you could appreciate from this diagram, this is the inguinal ligament. Here we have the femoral vein as the one of the most medial, because the most medial will be the inguinal ligaments. Then we will have the femoral vein, femoral artery, and the most lateral structure is the femoral nerve. The femoral nerve is dividing into anterior as well as posterior divisions, and it is going to supply the iliacus, pectineus, quadriceps, and all these muscles, including sartorius, which are muscles of the anterior compartment of the thigh. Now, after supplying these muscles in this area, which is also known as the adductor canal, and this is the adductor hiatus, it will be named as the saphenous nerve. So the component of the femoral triangle will be femoral nerve, but it can be asked that which is the component of the adductor canal, then the answer would be saphenous nerve. Now, saphenous nerve is going to supply skin around the knee joint, and it is also going to supply medial side of the leg as well. Whereas sensory innervation to the anterior as well as the medial aspect of the thigh is going to be from the main femoral nerve. So branches of the femoral nerve include anterior cutaneous branches, motor branches, which include branches to the muscles, and one long cutaneous nerve known as the saphenous nerve. Now, the anterior cutaneous branches penetrate the deep fascia to supply the skin in front of the thigh and knee, whereas the motor branches are going to supply the quadriceps femoris, which include rectus femoris, vastus lateralis, vastus intermedialis, vastus medialis, and the sartorius muscle. And there are iliacus and pectineus also being supplied by the very initial branches of the femoral nerve. Then we have the saphenous nerve, which is one of the third part or third division of the femoral nerve. Now it is going to supply medial side of the foot as well as leg and knee joint. So this is again the diagram to have a better idea about the femoral nerve. So next up we have the obturator nerve. Now regarding the obturator nerve, it has a root value of L1, L3. It is also one of the branch from the lumbar plexus, which is present on the posterior abdominal wall. Now it is responsible and it is concerned with the medial aspect of the psoas muscle upon entering the pelvis. And as we know that the most medial compartment in the thigh is the adductor compartment, and obturator nerve is going to supply all those adductors, whereas it is also going to supply the skin of the medial aspect of the thigh. So you need to remember the root values, and you need to know that which area is going to be the sensory supply and which are the muscles which each nerve is going to supply. So these are the frequently tested areas regarding nerves. So as you could see that this is the obturator nerve. It comes from the lumbar plexus. It lies on the medial side of the psoas, and then it enters the pelvis. And in this area, it is going to supply the adductor longus, adductor medius, adductor brevis, and it is going to supply a sensory area of the medial aspect of the thigh as well. So as the obturator nerve enters the thigh, it is going again to divide into two branches similar to the femoral nerve, into an anterior branch and a posterior branch, which are separated by the adductor brevis muscle. Now the posterior branch is supplying the obturator externus, adductor brevis, and part of the adductor magnus muscle. So you have to also know that which of the further branches are supplying which specific muscle. So you need to remember these details as well. So try to identify the common areas, like both in the femoral and obturator, both are dividing into anterior as well as posterior branches. So you need to remember that which branch is a motor and which branch is the sensory, so that you can easily get them right in the MCQs. So the anterior branch, it supplies the adductor longus, gracilis, adductor brevis, and pectineus, and the cutaneous branches innervate the skin on the medial side of the thigh. So the anterior branch of obturator is a mixed type, whereas the posterior branch is only motor. So that is the difference. Then we have the sciatic nerve. Sciatic nerve's root value is L4, L5, S1, S2, and S3. That is very important. So it is one of the nerves of the posterior compartment of the thigh, and it also supplies the gluteal region as well. Now it is going to innervate all the muscles in the posterior compartment of the thigh, and its further branches are going to supply muscles of the leg and foot. So basically it is sciatic nerve, which is later on going to divide into common peroneal and tibial nerves, but the common root area would be from the sciatic nerve. So as you could appreciate from this diagram that sciatic nerve is one of the thickest nerves in the body, and it is also coming from the lumbosacral area, with L4 to S1 being the root value. So again, a further dissection showing the posterior area of the thigh. Now sciatic nerve is present beneath the piriformis, and it passes in a curvy linear pathway, and it supplies all the muscles of the posterior compartment of the thigh. Later on, it divides into tibial as well as the common peroneal nerve, which we will talk about in detail in coming slides. Now, in the posterior compartment, the sciatic nerve lies on the adductor magnus muscle, and it is crossed by the long head of the bicep femoris muscle. Sciatic nerve divides into tibial as well as common peroneal. So, femoral divide and obturator divided into anterior and posterior branches, whereas sciatic nerve is going to divide into tibial and common peroneal. So over here, it is going to divide. So it is approximately the level of the start or just above the popliteal fossa. It is going to divide into these two branches. So common peroneal nerve is going to be one of the most lateral and superficial component of the popliteal fossa. and one of the component which is superficial is the tibial nerve in the popliteal fossa. So in the popliteal fossa, tibial nerve will go down and supply the posterior compartment of the leg, whereas common peroneal nerve is going to come to the anterior aspect and supply the anterior and lateral compartment of the leg. So that is the difference. So next we have the tibial nerve. Tibial part of the sciatic nerve, either before or after its separation from with the common peroneal, it supplies muscles in the posterior compartment of the thigh, uh, the long head of the bicep femoris, semimembranosus, and semitendinosus. So this is a concept which says that before its division, the root areas which is going to later on become the tibial nerve, those same fibers are supplying the muscles of the long head of the biceps, semimembranosus, and semitendinosus. However, there is an exception that the common peroneal part, which is coming from the directly from the roots, is supplying the short head of the bicep femoris. So that is the difference that you need to remember, because it is frequently tested, because the muscles which have dual nerve supply are frequently tested in the form of MCQs in various MCQ exams. So tibial nerve descends through the popliteal fossa and enters the posterior compartment of the leg, and later on continues to supply the sole of the foot. Now, tibial nerve is supplying the muscles in the posterior compartment of the leg, all the intrinsic muscle of the sole of the foot, except, now, always try to be good in remembering the exceptions, because they are very important. Except the first two dorsal antrochiae, which are innervated by the deep peroneal nerve, deep fibular nerve or deep peroneal, which is branch of the common peroneal nerve. Now, apart from the motor innervation, it also supplies the skin. It also has some sensory supply. That is the posterior lateral side of the lower half of the leg, the medial side of the ankle and foot and little toe, and skin on the sole of the feet and toes. So this is the diagram that from here common peroneal nerve is going to come into the anterior compartment, and tibial nerve is going to move down in the posterior compartment of the leg. And later on, it is at the ankle joint, it is going to divide into the medial plantar nerve and the lateral plantar nerve, which are going to supply innervation to the sole of the feet, the muscles, as well as the sensations on the sole of the foot. Then we have the common peroneal or the common fibular nerve. Now, the common fibular nerve innervates the short head of the bicep in the thigh, and it continues to supply the anterior and lateral components of the leg. Now, it is going to innervate the anterior and lateral components. Within common peroneal nerve, there are further two divisions, that is the deep peroneal nerve and the superficial peroneal nerve. Now, the deep peroneal nerve is going to supply the anterior compartment, whereas the superficial peroneal nerve is going to supply the lateral compartment of the leg. Now, it is in the foot, it is also going to supply the first two dorsal antrochiae. Apart from this, all the muscles in the sole are supplied by the tibial nerve. Now, regarding the skin, as it being the lateral nerve, because the medial side we have already discussed, it's supplied by the tibial. So, the lateral aspect of the leg, ankle, and the lateral aspect of the dorsum of the foot is also supplied by the common peroneal nerve. Now, there is an exception that the first web space is supplied by the deep peroneal nerve, whereas all the dorsal aspect of the feet along with the toes is supplied by the superficial peroneal nerve. So this is the difference. Except apart from this, you can see the diagrams which are effectively given in the netter to further be enriched with knowledge regarding the innervation of these nerves. So this is again the diagram. So common peroneal nerve comes on the anterior aspect and it divides at the level of the neck of the fibula, and it is a clinical correlate that the fracture of the head or neck of the fibula is going to result into damage to the common peroneal nerve. Now, common peroneal nerves damage is going to decrease the nerve supply to these extensors which are present over here, and the dorsiflexion will be absent. So, in damage of the common peroneal nerve, there will be foot drop. So, the tibial end enters the foot through the tarsal tunnel, and it divides into medial calcaneal branches, which supplies the heel at the uh, just below the calcaneus bone. So tibial nerve bifurcates with the posterior tibial artery into large medial plantar and a small lateral plantar nerve. Now the medial plantar nerve is a major sensory supplier to the sole of the foot. It innervates skin on most of the anterior two-thirds of the sole and adjacent surfaces of the medial third of 3.5 toes, which includes the great toe. In addition to this, a large area of the plantar skin, the nerve also innervates the four intrinsic muscles, which include abductor hallucis, flexor digitorum brevis, flexor hallucis brevis, and first lumbrical. Now, the lateral plantar nerve is going to supply all the intrinsic muscles of the sole of the foot, except muscles supplied by the medial plantar nerve. So, if you remember muscles for the medial plantar nerve, all the other exceptions will be supplied by the lateral plantar nerve. So here you could appreciate that tibial nerve, once it crosses the ankle joint, it is going to divide into medial and the lateral plantar nerve. Now they will be accompanied by the medial plantar artery and the lateral plantar artery. In the sole of the foot, the lateral plantar artery is going to form the plantar arch in addition to one of the vessels which is being given by the dorsalis pedis in the first web space. So this is again a diagram showing the medial and the lateral plantar nerves innervation. So this is a very important diagram. So this area, which I said is beneath the calcaneum, is supplied by the tibial nerve. This small area on the medial aspect or medial border of the foot is supplied by the saphenous, and on the lateral border, we have the sural. Whereas the 3.5 lateral digits and the sole is supplied by the medial plantar nerve, and 1.5 digits and the medial 1/3 of this area is supplied by the lateral plantar nerve. So this diagram is very important because it can be tested in descriptive form in the form of an MCQ. So this was all about the nerves. So now I will share the screen regarding the joints of the lower limb. So regarding the joints of the lower limb, so first of all, we have the hip joint. So regarding the joints, there are 2 to 3 things which are very important. You have to know their type. Articulations are not that difficult. I guess you can know them very easily, and you should be knowing about the muscles which are going to produce specific movement. So regarding the hip joint, the type it is a ball and socket variety of the synovial joint. So both things can be tested in the form of an MCQ, that is it a ball and socket joint, or it can also be given regarding hyaline joint, cartilaginous joint, then the option would be the synovial joint. Now regarding the articulation, the head of the femur articulates with the acetabulum of the hip bone. As you could appreciate from this is the acetabulum, and the head of the femur is going to articulate with this area to form the hip joint. So the head of the femur forms more than half of a sphere, and it is covered with hyaline cartilage. So in this area, in between the bones, there is cartilage, and that is known as the hyaline cartilage. Now, acetabulum presents in the form of a horseshoe-shaped lunate articular surface, an articular notch, and articular fossa. You do not need to know all these details. Just know that acetabulum with the head of the femur is going to form this joint. There is going to be a joint capsule, and in between these two bony articulations, there is a cartilaginous hyaline cartilaginous rim present. So what are the factors which are going to determine the stability? Now, the depth of the acetabulum, tension and strength of the ligaments around this, the strength of the muscles, the length and obliquity of the neck of femur, and the atmospheric pressure. A fairly wide range of mobility is possible because of the fact that femur has a long neck which is narrower than the equatorial diameter of the head. So these are the ligaments. There are three important ligaments, the iliofemoral ligament, pubofemoral ligament, and the ischiofemoral ligament. So we have three bones which are making the acetabulum. We have discussed this in the bony section. We have the ilium, pubis, and ischium. Now, from each of these bone, there is going to be origin, and the insertion side of the ligament will be in the femur. So at the end, we will be having femur, and we will have three names which are the just similar to the name of the bones of the hip. Now, out of these, iliofemoral is present in the form of an inverted Y, and it is one of the most strongest ligaments of the body. So these two facts are need to be known about the iliofemoral ligament. Now, regarding the blood supply, the vascular supply of hip is from the obturator artery, and more importantly, from the medial and the lateral circumflex femoral arteries. Now, apart from this, superior and inferior gluteal arteries can also be some contributing factors, but the primary blood supply which can be tested is from the medial as well as the lateral circumflex femoral arteries. However, in only 10% of the individuals, the obturator artery is going to supply. Now, there could be another MCQ that which is a predominant artery in children? Then the answer will be obturator artery. And if they ask you that out of medial and lateral, which has more like percentage supplying, then that would be the medial. So there are different MCQs which you need to understand regarding the blood supply of the hip joint. And all of these vessels are forming a network of thick anastomosis around the hip joint. So this is the diagram showing the anastomosis between the lateral circumflex and the medial circumflex arteries. And as a consequence of the fracture of the neck of femur, the blood supply is not going to reach the head. And as a consequence, the head will start to degenerate. And that is known as the avascular necrosis of the head of the femur. Now, regarding the movements at the hip joint, the forward movement is flexion, the backward movement is extension, and extreme back movement is the hyperextension. Moving away from the center of the body is the abduction, and moving towards the center is the adduction. There are two specific movements, that is the medial rotation and lateral rotation, which can be appreciated from this diagram, that if the leg is moved outward, then the hip will move medially. But if the leg is rotated inward, then the hip will move in the lateral direction. Now, which are the muscles which are going to perform all these movements? So for flexion, we have psoas major and iliacus. For extension, we have gluteus muscles and the hamstrings. For adduction, we have adductor group that includes longus, brevis, and magnus. For abduction, which is frequently tested, we have gluteus medius and minimus. So gluteus maximus is for the extension, whereas medius and minimus is for the abduction. So regarding the medial rotation, the iliotibial band and the anterior fibers of the gluteus medius and minimus. For the lateral rotation, we have the two obturators, the two gemelli, and the quadratus femoris. So they are known as the small lateral rotators of the hip joint. So regarding some clinical correlates, congenital dislocation is more common in hip than in any other joint of the body. The head of the femur slips upward onto the gluteal surface of the ilium because the upper margin of acetabulum is developmentally deficient, and that causes lurching or the Trendelenburg sign. So regarding the knee joint, it is one of the largest and most complex joint of the body. Now the complexity is because it is formed by three subunits, that is fusion of the lateral femorotibial, the medial femorotibial, and the femoropatellar component. So this is for the easy revision. We do not have to remember the detail. You can only look on this on the diagram. So this is the patellofemoral component. Now these are the two medial and lateral femorotibial components. Now these are the bony part of the knee joint. However, there are a lot of ligaments. We have the lateral as well as medial meniscus. We have the medial collateral ligament, which is this, and we have the lateral collateral ligaments, which is over here. And then we have the ACL and PCL. Now this is the ACL, which is going like this, and then the PCL is going to be like this. So these are the 6 sub-components of the knee joint as well. So it is a compound synovial joint incorporating 2 condylar joints between the condyles of the tibia and femur, and 1 saddle joint between the femur and the patella. So we have gone through the articular surfaces. So these are the femoral condyles, and these are the areas on the tibia which are going to articulate with this area. And in the femur, we have this area where the patella is going to articulate in the femoropatellar component of the knee joint. So regarding the ligaments, we have divided them into extracapsular and intracapsular. Regarding the extracapsular, the 2 which are very important and frequently asked in the MCQs are these 2. However, you can go through the names of the other, which include the fibrous capsule, ligamentum patelli, oblique, and arcuate popliteal ligament. Now, the important ones are the medial collateral and the lateral collateral ligaments. Now, these are the 2 ligaments which are going to provide lateral and medial stability to the knee joint. That is why they're important, and they are present outside the capsule of the knee joint. So that is why they are known as the extracapsular. Regarding the intracapsular, all are important. You can memorize them in the form of 2 groups, that is the ACL and PCL, that are the cruciate ligaments, and the menisci, the lateral and medial menisci. Now, we have different bursas around the knee joint. First of all, we have the suprapatellar bursa, the prepatellar bursa, deep infrapatellar bursa, the superficial infrapatellar bursa, and the pretibial bursa. You could appreciate them from this diagram that this is the suprapatellar bursa, which is present above the patella between the femur and the quadriceps. Then we have the infrapatellar, which are further divided into 2, the deep and the subcutaneous or the superficial. So as you could appreciate from this, that the ligamentum patelli is going to be the landmark. If it is present deep to it, it will be deep infrapatellar because it is present below, and then it is further going to be divided like this. So it is the one which is present above is suprapatellar. The one which is present below is infrapatellar. Infrapatellar is further divided into the superficial as well as the deep. Then we have the semi-membranous, which is present around the semi-membranous area, and these are the subsartorial bursa. And there is one superficially present subcutaneous prepatellar bursa as well. So if you could focus on this diagram, it will be very easy for you to understand the location of all these bursas. So regarding the blood supply, we have a rich anastomosis from the femoral as well as the popliteal artery. And you need to remember the names which can be tested. There is a superior, so there is going to be a superior medial, a superior lateral, an inferior medial, and an inferior lateral genicular artery. So these 4 are done. Now then we have the descending genicular, which is going to come from above like this. And then there is going to be one branch that is coming from here, that is the recurrent. So if you divide this location, then you can have 3 groups: the superior, medial, and lateral, the inferior, medial, and lateral. One branch is coming from above downward, that is the descending genicular, and then one branch is coming from the anterior tibial, which is coming above. So if you can even draw this diagram on your notes, it will be very easy for you to later on revise and go through these arteries in a quick time. So as you could see, I have simplified this diagram. You can go through this as well. The superior lateral, the superior medial, the inferolateral, inferomedial, the recurrent branch, and the descending branch. So regarding the nerve supply, following nerves supply the knee joint. We have the femoral nerve, the sciatic nerve, obturator nerve, and infrapatellar branch of the saphenous nerve. Now, out of these, saphenous nerve is very important because with reference to the femoral nerve, which I have explained, it divides into anterior and posterior branches, and then later on it becomes the saphenous nerve. So all this area is primarily supplied by the saphenous. However, there are small contributions on the medial and the posterior aspect by these nerves as well. So regarding the movement, at the knee joint, the flexion is caused by the hamstrings. Sorry, and the short head of the biceps, gracilis, sartorius, gastrocnemius, and popliteus. Out of these, hamstrings and the biceps short head is important. Extension is caused by the quadriceps. Now, medial rotation and lateral rotation, if you could identify this from the diagram, which I've explained in the muscle section, semimembranosus and tendinosus are present on the medial side, and bicep femoris is present on the lateral side. So if you know their location, it will be very easy to add the type of rotation. The one which is present on the medial side is responsible for medial rotation. The muscle which is present on the lateral side is going to be responsible for the lateral rotation. So it's quite easy to remember. Similarly, the muscle which are present in anterior compartment are going to cause the extension of the knee, and the muscles of the posterior compartment are primarily responsible for the flexion at the knee joint. So locking and unlocking. It is a mechanism that allows the knee to remain in a position of full extension. Now, locking occurs as a result of the medial rotation of the femur during the late stage of extension. So what you need to remember is that which muscle is going to cause locking and which is going to produce unlocking, because these are separately tested. So locking is produced by the quadriceps femoris and unlocking occurs as a result of the lateral rotation. So locking is as a result of medial rotation and it is by the quadriceps, whereas unlocking is through the lateral rotation and it is caused by the popliteus. So these are two things which are important. Later on, you can also add the third point that in the late stage of extension, locking, and in the initial stage of flexion, we have the unlocking. So if you can write them down in the form of differences in your book or notes, it will be very easy for you to later on revise this in a very quick manner, because this is the concept which most of the students find very difficult because it is one of the key areas which are tested in the MCQs. So regarding the clinical pathologies, we have genu valgum, that is the inward movement of the knees. Then we have genu varum, which is the outward movement of the knee. For one of the pathology for genu varum is the rickets, which you need to know. This is the normal knee. So menisci are a C-shaped structure. These are the visualizations of certain type of injuries. It can have a vertical injury, a transverse injury, or a peripheral flap injury, or bucket handle injury, and a parrot beak. Out of these, the bucket handle injury is very important for the MCQs. Now, regarding the cruciate ligament injuries, there could be a partial injury, there could be a complete injury. So, in case of an ACL injury, there will be anterior dislocation or translation of the tibia with reference to femur. In posterior cruciate ligament injury, there will be posterior translation of the tibia with reference to femur. So, these are the 2 points which you need to know regarding the ACL and PCL. So this is a diagram where you can visualize the tear of the ACL. So ACL is present like this and PCL is present posteriorly over here. And the most likely mechanism is on a steady foot, if there is a very large force which rotates the tibia and femur in opposite direction, the word is the twisting force, then that E word can be a giveaway for the ACL injury. So similarly, we have the posterior cruciate tear, which will result into posterior sag, and the posterior test will be the PCL tear for, so I forgot the name, and that will be positive as well. So next up we have the collateral ligaments. So these collateral ligaments can also be damaged. Now there is a very important concept. So if the force will be from the outside to inside, it will damage the medial side. But if the force will be from inside to outside, it will damage the lateral ligament. So that is very important. So outward to inward force is going to damage the MCL, whereas inward to outward force is going to cause tear in the lateral ligament, that is otherwise known as the LCL. So for the ligamentous injuries, you need to memorize the type of injuries, the type of forces, so that it will be very easy for you to answer. You will not have to think for a long time. So last but not the least, we have the ankle joint. In the ankle joint, it is a synovial joint of hinge variety. So that is very important. Now regarding the articular surfaces, we have inferior aspect of the tibia, inferior aspect of the fibula, and the anterior or superior aspect of the talus bone. So these are the three components which on articulation is going to form the ankle joint. To the lower end of tibia, the lateral malleolus of the fibula, and the superior aspect of the talus is going to be upper and medial lateral. All of these areas going to form the of the talus is going to articulate and form the ankle joint. So structurally, this joint is very strong, and the stability is ensured by the close interlocking of the articular surfaces, which you can visualize over here. It does not have much space like the space you visualize in the hip joint or knee joint. As they have more mobility, they have more space. Ankle joint is a very tightly compact area. It does not have much space, and that is the thing, that it is more stable because it has to bear weight of all the body. So, and there are lot of ligaments present on both sides, anteriorly, posteriorly, medially, as well as laterally. And there is a network of tendons which are going from the leg into the foot anteriorly as well as posteriorly. So all these structures, these ligaments, these muscles, these articular surfaces are going to contribute to the stability of the ankle joint. So regarding the ligaments, we have the fibrous capsule, and then we have the medial or the deltoid ligament, and we have the lateral ligament. So there are different components of the medially present deltoid ligament, which includes the posterior tibio-talar, tibio-navicular, and tibio-calcaneal. Now we have tibia, talus, calcaneum. So we have to just add tibia with the reference to the bone. So this is tibio-talar, this is tibio-navicular, and the one coming from the calcaneum will be the tibio-calcaneum. So it will be like this. It will be an articulation with this and like this. So with tibia, you have to add the name of the three bones which are present in close association. So you need to remember these names. These are very important, and I have given you the way to remember. All right. Similarly, on the lateral side, we have different components. Similarly, we have calcaneum, we have the fibula and tibia. So there will be, and we have talus. Now, on the medial side, the predominant name that you need to add is tibia. Whereas on the lateral side, we have the fibula. So we will be adding fibula to that. Talofibular, calcaneofibular, and the tibiofibular. So if you can understand this from the diagram, it will be very easy for you to later on remember. And in this area, we just have to add anterior and posterior for the tibiofibular, whereas all the rest, and also for talofibular as well, we have to add just anterior and posterior. So remember that tibiofibular, you have to focus on this word. You have to focus on talofibular, and then you have to focus on the calcaneofibular word. Rest is just adding anterior and posterior, so that will not be a problem for you. So regarding the blood supply, it is supplied by the anterior and posterior tibial and the peroneal arteries. And regarding the nerve, it is supplied by the deep peroneal and the tibial nerve. So anything that is crossing it is also giving supply. So anteriorly, we will be having tibial, anterior tibial. Posteriorly, we will be having the posterior tibial. And from the lateral component, the peroneal artery is going to come over here and also going to supply the ankle joint as well. So regarding the movement, we have the dorsiflexion, that is the forward and upward movement, and we have the plantar flexion, which is the downward or backward movement. Now, these two movements occur at the ankle joint, which is present between tibia, fibula, and talus. Whereas inversion and eversion occurs at the subtalar joint, which is present between the talus and calcaneum. So this is the difference that you need to know, and it is frequently tested in the form of MCQs. So these are the muscles. For dorsiflexion, the principal muscle is tibialis anterior. And for plantar flexion, we have the posterior compartments, gastrocnemius and soleus. You do not need to know the accessory compartments, accessory muscles, but if you know that the rest of the anterior compartment is going to be responsible for the dorsiflexion, and muscles of the posterior compartment of the leg is going to be with the plantar flexion. So regarding the clinical anatomy, the so-called sprains of the ankle are almost always because of the abduction movement of the subtalar joint, although few fibers of the deltoid ligaments are also torn. True sprain of the ankle is caused by the forced plantar flexion, which results into tear of the anterior fibers of the capsule, and the joint is unstable during the plantar flexion. So these are just important points to remember. So dislocation of the ankle is rare because joint is very stable due to presence of the deep tibiofibular socket. Whenever dislocation occurs, it is accompanied by the fracture of the bones which is present around it, which could be one malleolus or the other malleoli. Ankles, acute sprain of the ankle when the foot is plantar flexed and excessively inverted. So this is the mechanism. You need to remember that what is the mechanism for the sprain, because more common injury to the ankle joint is the sprain, and this is the mechanism. Lateral ligaments are torn, giving rise to pain and swelling as well. Acute sprain of the medial ankle occur in excessive eversion, leading to tear of strong deltoid ligament. The optimal position of the ankle to avoid ankylosis is of one of the slightly plantar flexed. For injection into the ankle joint, the needle is introduced between, so that is important clinical, between the tendons of the extensor hallucis longus and tibialis anterior, and the foot will be partially plantar flexed. So regarding the proximal tibiofibular joint, it is an articulation between the lateral condyle of the tibia and the head of the fibula. It is a synovial plane gliding joint, and it has anterior and posterior ligaments which strengthens it, and it has a capsule, and the common peroneal nerve supplies the joint, and it is also present in close area of that. Now, there is only a gliding movement which occurs at the proximal tibiofibular joint. Similarly, we have a distal tibiofibular joint, which is the fibrous joint, otherwise known as the syndesmotic joint. So this is again an articulation of the distal fibula and the lower end of the tibia. And there is no capsule, and blood supplies from the peroneal artery, which is present on the lateral side. So the nerve supply of the tibiofibular joint is the deep peroneal, tibial, and saphenous. The joint permits slight movement, just like the proximal tibiofibular joint. So this area is very important. This is the tibia. Then we have the fibula. The specific name for this area is the lateral malleolus, and this area is the medial malleolus. Now it is articulating with the talus bone, and this is the ankle joint, which you could appreciate over here. And this joint or this area is known as the distal tibiofibular joint, otherwise known as the syndesmotic joint as well. So regarding the joints of the foot, you just need to know their names. They are not frequently tested because there are a lot of them and there is no much movement on them. So we have the intertarsal, tarso-metatarsal, intermetatarsal, metatarsophalangeal, and the interphalangeal joints in the foot. So you just need to remember the names. We have the ankle joint, on which dorsiflexion and plantar flexion occurs. Then we have the subtalar joint on which inversion and eversion is taking place, and the rest of the joints are just to know their names. We have the talonavicular, calcaneocuboidal, and all the rest of these joints. So the main intertarsal joints are the subtalar and talocalcaneal, while you just need to know the names of the rest, which are just easy as you could, if you can identify or remember the sequence of the bones, it will be very easy for you. So here we have the talus, here we have calcaneum. In front of the talus, we will have navicular. With calcaneum, we will have cuboid. And these are the cuneiforms. We have the medial cuneiform, intermediate cuneiform, and the lateral cuneiform. And then we have the metatarsals, and then we have the phalanges. So this was all regarding the joints of the lower limb.